Hello, it's Dmitry again. Today we'll be covering Blueprints Psychiatry Chapter 9, Miscellaneous Disorders. Now, as you can imagine, this chapter is about miscellaneous disorders, so it's kind of a grab bag a little bit. A reminder that this is the 5th edition of Blueprints Psychiatry. There is a 6th edition that is out there, and it is somewhat different in terms of the content in principle or in theory, and the organization is somewhat different as well. So if you're using a more recent edition, there's going to be some differences between the two. And if you're using the 5th edition, well, that's what I'm using here with this PDF. So you can just follow along here if you want. So let's get into it. Miscellaneous disorders. Miscellaneous disorders do not refer to any diagnostic and statistical manual of mental disorders, 4th edition, DSM-4 classification, but rather to psychiatric diagnoses not covered elsewhere in this book. Generally, these diagnoses are either less common, less understood, or less frequently the focus of psychiatric practice than the disorders previously covered. Although many of these disorders are not uncommon, they seldom come to psychiatric attention for a variety of reasons. That is to say, they may be treated by other medical specialists, patients may not mention them, or they may not be detected adequately. Table 9.1 lists the categories of disorders discussed in this chapter. Another thing to keep in mind is that some of these disorders are actually grouped into some of the other chapters in the 6th edition. I don't know for sure whether or not miscellaneous disorders is a chapter in the 6th edition, but I do know that some of the disorders that we'll be covering in this chapter would otherwise be covered in chapters that are already been read or will be read in the future by me and are covered in normative chapters in the 6th edition. That is to say, let's say, for example, chapters 1 through 8 or something like that in the 6th edition might cover disorders that are otherwise mentioned in this grab bag chapter from the 5th edition. So just a different way of organizing information. I can't say for sure that miscellaneous is not a chapter within the 6th edition. I just know that some of the disorders we'll be covering today would otherwise be covered in some of these other chapters. So anyway, let's get into it. Dissociative disorders. Dissociative disorders are characterized by disturbances in the integration of mental functions. These disturbances are manifested by a loss of memory or for personal information or identity, division of consciousness and personality into separate parts, and altered perception of the environment or sense of reality. Table 9.2 lists DSM-4 defined dissociative disorders. Dissociative amnesia. In dissociative amnesia, an individual develops a temporary inability to recall important personal information. The amnesia is more extensive than forgetfulness and is not caused by another medical psychiatric condition. That is to say, head trauma, for example. The inability to recall information may take several forms. In localized amnesia, information is lost for a specific time period, that is to say, a time associated with trauma. In selective amnesia, some information during a given time period is retained, but other information is lost. In generalized amnesia, personal information is lost for the entire lifespan. That's pretty serious. In continuous amnesia, there is inability to recall information from a single point in time to the present. In systematized amnesia, particular categories of information are lost to retrieval. So there's a lot of different possibilities when it comes to amnesia. Dissociative amnesia is more common in people exposed to trauma, for example, those exposed to battle or natural disaster. Dissociative fugue. Dissociative fugue is an amnestic disorder characterized by an individual's sudden, unexplained travel away from home, coupled with amnesia for his or her identity. In this condition, patients do not appear mentally ill or otherwise impaired in any other mental function, including memory. In fact, patients are quite capable of negotiating the complexities of travel and interaction with others. In rare cases, an individual will establish a completely new identity in the new home. Dissociative fugue is typically precipitated by severe trauma or stressor and eventually remits without treatment. Very strange condition, the idea that somebody just kind of like wanders off to some other different place and basically lives a new life because of some sort of trauma or stressor that they had initially. And again, in some cases, quite just taking on a completely different identity in some cases. Very strange. Dissociative identity disorder. Dissociative identity disorder, formerly called multiple personality disorder, is a controversial diagnosis in psychiatry. The diagnosis of a dissociative identity disorder requires the presence of two or more separate personalities, alters, that recurrently take control of an individual's behavior. Individuals with this disorder often have amnesia for important personal information, also known as losing time. The various personalities, the average number by available surveys is 7 distinct personalities. The average is 7, okay. May be unaware of each other's existence and thus may be quite confused as to how they arrived at certain places or why they cannot recall personal events. At other times, one or more personalities may be aware of the others, a condition known as co-consciousness. Some personalities may display conversion symptoms or self-mutilating behavior. The alters may be of varying ages and different genders and demeanors. Table 9.1, Miscellaneous Disorders. So we have, within the context of miscellaneous disorders, we have dissociative disorders, somatoform disorders, adjustment disorders, sexual and gender identity disorders, sleep disorders, infectious disorders, and malingering. So let's go back into this. Dissociative identity disorder is most common in females and has a chronic course. Individuals with dissociative identity disorder are highly suggestible and easily hypnotized. Most report a childhood history of severe physical or sexual abuse. Satanic or cult abuse reports also are common. In some cases, these reports of abuse cannot be verified, leading many clinicians to believe that individuals with dissociative identity disorder may suffer from memories of events that did not occur. Whether these memories are true or false, they cause a great deal of suffering. And I'm going to go again, this is the table again. You know what? Let me just go read the rest of this and I'll go back to the table. Disagreement over the very nature of dissociative identity disorder has led to divergent treatment opinions. Some clinicians believe that ignoring the different personalities will cause them to recede, based on the notion that the easy suggestibility of these patients will lead to reinforcement of alters if they are discussed. Others believe that long-term psychotherapy, exploring the various personalities and integrating them into a whole person, is the treatment of choice. Medication treatments are usually targeted at symptom relief or comorbid conditions. Dissociative identity disorder may be best conceptualized as a trauma spectrum disorder associated with severe trauma exposure. Patients with dissociative identity disorder have a very high rates of PTSD, about 70%, and about 50% of patients with dissociative identity disorder also have somatization disorder. Disorder. Mood disorders are also present in a majority of patients. Okay, so let's talk about the table again, about dissociative disorders. We have dissociative amnesia, temporary inability to recall important personal information, more serious than simple forgetfulness. We have dissociative fugue, amnesia for one's identity coupled with sudden unexplained travel away from home. Dissociative identity disorder, which we just covered, presence of two or more separate personalities that recurrently take control of a person's behavior. And we have depersonalization disorder, which we'll be going into soon, which is a pervasive sense of being detached from or being outside of one's body. Depersonalization disorder. Depersonalization disorder is characterized by persistent or recurrent experiences of feeling detached from and as if one is outside observer of one's mental process or body, DSM-4. Individuals with this disorder may complain of a sense of detachment, of feeling mechanical or automated, and of absence of affect or sensation. Individuals with a depersonalization disorder are easily hypnotized and prone to dissociate. What about somatoform disorders? So somatoform disorders are characterized by the presence of physical signs or symptoms without medical cause. In addition, they are not willfully produced by the individual, namely in contradistinction to factitious disorder and malingering. The symptoms of somatoform disorders are assumed to be subconscious in origin. The somatoform disorders are listed and defined in Table 9.3. Again, the idea here is that the person let's say, for example, has pain or something, they have some sort of problem, they feel the problem, they're not lying to you, they're not trying to deceive you, but they also don't really physically have an issue. There's no physical issue, but they feel there's a problem, and they're not trying to lie to you or something like that. So Table 9.3, somatoform disorders, somatization disorder, chronic multiple medical complaints that include pain, GI disturbance, sexual symptoms, and pseudoneurologic symptoms that are not caused by a medical illness. Undifferentiated somatoform disorder. A less severe form of somatization disorder involves fewer complaints and a briefer course. Conversion disorder. Complaints involving sensory, such as numbness, and voluntary motor, such as paralysis, function that are not caused by neurologic dysfunction. And I think that there's a new name for conversion disorder, so just give me a second to see if there's a new name for that, because I think they always update these kinds of things. They say conversion disorder is also called functional neurological disorder. So they call that functional neurological disorder in the big 2026, okay? So functional neurological disorder for conversion disorder. Pain disorder. Pain is the major complaint. If medical causes are present, psychological factors have a major role in mediating the expression and impact of pain. Hypochondriasis, preoccupation with having a serious disease based on a misinterpretation of bodily function and sensation. Body dysmorphic disorder, excessive concern with a perceived defect in appearance. What about somatization disorder? Somatization disorder is diagnosed when an individual has multiple medical complaints that are not the result of medical illness. The specific DSM-4 criteria are narrow and specific, requiring pain in 4 different body sites or involving 4 different body functions, 2 gastrointestinal symptoms other than pain, 1 sexual symptom other than pain, and 1 pseudoneurologic symptom other than pain. In addition, some symptoms must have begun before the age of 30 and persisted for several years. Individuals with somatization disorder often have a history of complex medical and surgical treatments that may actually lead to iatrogenic complications of treatment. Patients with somatoform disorder frequently have multiple physicians, make frequent office and hospital visits, and may seek disability because of their conviction that they are severely and chronically medically ill. This disorder is more common in females, approximately 80% of cases, and its incidence is increased in first-degree relatives of those with somatization disorder. Familial and genetic studies have also shown that male relatives of individuals with somatization disorder have an increased incidence of antisocial personality disorder and substance abuse. Okay. So this might be some underlying genetic effects that are leading to certain kinds of maybe neurological dispositions leading to, I guess, distinct but nevertheless pathological behavioral outcomes. Very strange. Adoption studies suggest genetic influence in this disorder. Various theories have been proposed to explain this disorder. Early psychoanalytic work focused on repressed instincts as causative. More modern theorists propose that somatization symptoms may represent a means of nonverbal interpersonal communication. Biologic findings have revealed abnormal cortical function in some individuals with this disorder. Overall, the disorder appears to be best explained using an integrated biopsychosocial approach grounded in cognitive interpretations and learning theory. Cognitive behavioral theory is the most effective treatment of somatization disorder. Antidepressant medications are also helpful in patients with or without comorbid depressive symptoms. Additional strategies for treating somatization include regular, structured visits by a single physician with the goal of avoiding excessive or invasive diagnostic workups, and visits by the patient to other physicians or emergency wards. Adjustment disorders. According to the DSM-4, adjustment disorders are symptoms, changes in emotional state or behaviors that arise in response to an identified psychosocial stressor that is out of proportion to what is expected in usual human experience. Adjustment disorder is not diagnosed and the symptoms occurred in response to a psychosocial stressor so severe that an individual meets criteria for another Axis 1 disorder, that is to say, major depression. Symptoms in response to bereavement do not meet criteria for the diagnosis of adjustment disorder. Adjustment disorders occur within 3 months of the identified stressor and usually resolve within 6 months, unless the stressor becomes chronic. Table 9.4, Sexual Response Cycle. So we have here desire, excitement, orgasm, and resolution. Okay. Well, a little suggestive, I guess. Desire. Initial stage of sexual response consists of sexual fantasies and the urge to have sex. Excitement consists of physiologic arousal and the feeling of sexual pleasure. Climax, orgasm, peaking sexual pleasure, usually associated with ejaculation in men. Resolution, physiologic relaxation associated with the sense of well-being. In men, there is usually a refractory period for further excitement and climax. What does this have to do with everything else we just read? Well, not much, but we'll be getting into some of that stuff here. So sexual and gender identity disorders. The DSM-4 classifies these disorders into sexual dysfunctions, paraphilia, and gender identity disorders. Sexual dysfunctions. Sexual dysfunctions are sexual disorders associated with the alterations in the sexual response cycle, or with pain associated with sexual activity. The specific sexual dysfunctions are defined in Table 9.5, which we'll be going into right here. So Table 9.5, specific sexual dysfunctions. Sexual desire disorders. You have a hypoactive sexual desire disorder, where sexual fantasy and desire for sex are very low or absent. And you also have a sexual aversion disorder, aversion to genital sexual contact with another person. So it's a little bit different, but they are both related to a kind of desire disorder. Sexual arousal disorder. We have a couple things here. We have female sexual arousal disorder, where it says inadequate vaginal lubrication and inadequate engorgement of external genitalia. So basically the woman is not really being physiologically aroused. And then male erectile disorder, inability to attain or maintain an erection. So again, it's a matter of physiological arousal. Orgasmic disorders, we have 3 here. We have female orgasmic disorder. Orgasm is absent or delayed. Sexual excitement phase is normal. Male orgasmic disorder. Orgasm is absent or delayed. Sexual excitement phase is normal. And then we also have premature ejaculation. Orgasm and ejaculation occur early and with minimal stimulation. We also have these things called sexual pain disorders. We have dyspareunia, genital pain in association with sexual intercourse, and then vaginismus, which is involuntary contraction of external vaginal musculature as a result of attempted penetration. So again, these are a little suggestive. I wouldn't characterize it as graphic. We're just trying to, in a very clinical way, explain sexual dysfunction, which is a thing you probably would have to be aware of if you're somebody who is a doctor and might have a patient who has one of these problems. We also have sexual dysfunction resulting from a general medical condition and substance-induced sexual dysfunction. Now onto paraphilias. So paraphilias include sexual disorders related to culturally unusual sexual activity, Table 9.6. A key criterion for the diagnosis of paraphilia, as in all psychiatric disorders, is that the disorder must cause an individual to experience significant distress or impairment in social or occupational functioning. In other words, an individual with unusual sexual practices who does not suffer significant distress or impairment would not be diagnosed with a psychiatric illness. And this goes into a whole other thing about, we were talking about before about pica. We're talking about if you're a person who eats dirt and you live in the United States, you have pica. But if you're a person who eats dirt in West Africa, that's just normal because your culture is cool with that. And it's one of those things where you kind of say, okay, so basically certain behaviors are being pathologized depending on which country you live in, depending on what culture you live in. and also depending on what kind of society you live in. And this DSM-4 and DSM-5 is not necessarily super different in that respect. Not only does it acknowledge that in an immediate sense, it acknowledges that that's true. That it's going to be somewhat kind of culturally dependent in theory. Now you could say, well, that seems a little bit arbitrary. It is a little bit arbitrary in truth. However, it is true that if you're a person who's very, let's say, has dispositions that are very alien to your society's culture, that might be an indication of a behavioral abnormality. Well, I mean, it would be a behavioral abnormality. It might reflect an actual neurological or psychological abnormality underlying it. So it's not completely unfair, you know. And to give another example of arbitrariness, you know, let's say, for example, you're a guy who is 6'1", right? That's kind of tall, but it's not necessarily abnormally tall. It's tall, right? But if you're a guy who's 6'1", and you're living among the pygmies, like the Twa pygmies in Central Africa or something like that, or I guess they're like in Rwanda, I believe. I think Twa pygmies are from that area. If you're a 6'1" guy and you're a pygmy, that doesn't make any sense, right? And so even if you want to say, for example, and that's a genetic example, we're talking about here culture, which is a lot more fluid typically. And so even though we could say, oh, it's a little bit arbitrary, where do we draw the line, that kind of thing, it is a point to be made that when you're a psychologist, you're not necessarily thinking about the morality of something. You know, we're not talking about, is it morally right to do certain weird things in the bedroom? We're not asking about that in principle. We're asking about whether or not the behavior is maladaptive given your particular cultural context, if that makes any sense. You know, for example, adultery. A lot of psychologists are going to say, yeah, you probably shouldn't be cheating on your wife. However, is the desire to have, if you're a guy, and let's say you're a very wealthy, well-to-do guy, is the sexual desire to have sex with women is it pathological? Probably not necessarily, but you might have in some cases a hypersexual tendency that is actually causing social problems for you. But if you live in a society where you're a polygamist and you actually have multiple wives, well, then all of a sudden it's not a pathology. If you're a guy who has a long-running affair with your wife in a Western country, that might be considered a problem for you socially because maybe your wife finds out, maybe you're a politician, it's a big scandal. But it might, if you're just a guy who has 2 wives and you live in, I don't know, Jordan or something like that, or Saudi Arabia, all of a sudden that doesn't become a pathological issue, right? Or it doesn't become a problem for you. You have a second lover. Of course, yeah, you have a second wife, right? So it's sort of it's not a question about the morality of something we're talking about in principle. Doesn't mean you should be amoral, right? Doesn't mean you should be apathetic about morality, but it is a question about when we talk about psychiatry or any other field of medicine. Is the behavior that this person has pathological? Is it causing harm to them physically or socially and that kind of thing, psychologically? Because there is a distinction between the two. Gender identity disorder. Gender identity disorder remains a controversial diagnosis in psychiatry. Individuals with this disorder experience distress and interpersonal impairment as a result of their desire to be a member of the opposite sex. Criteria for the diagnosis: it requires a pervasive cross-gender identification and persistent discomfort with one's assigned sex. I hate that terminology. I was assigned male at birth. It's like, well, I mean, you are male because you have a phallus, right? It's, it's like, okay. In addition, I was assigned, it's like saying, I'm a hair below 6 feet tall. I was assigned 6 feet tall. It was like, no, you're just that tall, right? You know what I'm saying? Like, I was assigned white at birth. It's like, I think you're just that race of people. Like, it's kind of a goofy disposition. And in that case, for example, too, even that's not even a great position because we do have categorization schemes that are specific to us as a species of humans. There's not necessarily a Caucasian race or an African race in lemurs or something like that, but there is a male and female in lemurs, right? So that is an undergirding, consistent biological reality that exists independent of humanity, right? Well, in this case, in other cases, it might not. There's very few things that are as fundamental to a species as something like whether or not they're a sexually dimorphic species with, or essentially sexually reproductive species versus one that is asexual, like a sea sponge or something like that. So, but they like to use this terminology, assigned sex at birth or something like that. I think it's kind of ridiculous. Anyway, in addition, the diagnosis is made only in those individuals, because it's basically trying to pretend that it's just like, arbitrary game of chance, you roll the die kind of situation, when really it isn't. In addition, the diagnosis is made only in those individuals who do not have any intersex condition, that is like ambiguous genitalia. So for example, if you're a person who has ambiguous genitalia because of a chromosomal abnormality, because of a hormonal issue, let's say for example you have CAH for example, and so you might have ambiguous genitalia. If you have some sort of identity issue related to your gender, sex, that kind of thing, and you have ambiguous genitalia, that's not considered part of gender identity disorder because you are considered, it was ambiguous in the first place, rather than a person who is very obviously physiologically, biologically male. You could just, you look at the person like, yeah, that is a guy, and the person thinks that he thinks that he is a woman, or vice versa. You have a woman who's very obviously a woman. You look at her face, you look at her body type, and if you wanted to look at her genitalia, you would say, yeah, this is a female person, this is a female human being, and she thinks, well, I'm a man. It's like, well, that's what gender identity disorder is kind of relating to. Children with this disorder may engage in gender atypical play. Adults may assume the societal role, dress, and behavior associated with the opposite sex. In addition, patients with gender identity disorder may seek sex reassignment surgery and hormonal supplements. Individuals with gender identity disorder appear to have the same range of sexual orientations as do persons without this disorder. Which is to say, if you're let's say you're a male and you identify as a woman, you might still be sexually attracted to men, to women, or to both. So that's something to be aware, and vice versa. If you're a female, you're a woman, you're female, you identify as a man, though, you might be sexually attracted to men, as females typically are, and you might be attracted to women, and you might be attracted to both, or I guess neither, right? It's a possibility too. So all those things exist, and of course they might retroactively characterize that as, I'm a trans man and I'm gay for men. You typically would say if you're a woman, if you're female and you find males attractive, you would say, oh, you're heterosexual, but now you're apparently a gay trans man or something, right? That's the idea, I guess. Anyway, let's talk about table. Let's go into paraphilias a little bit. Well, let me go skip that back to the finishing up the. They don't finish it. Okay, that is the finish point. So I want to go into the GID stuff again. Now, this book is this is the 5th edition. I can't tell you. I don't know what year this was made. Let me go see if I can finish up the chapter just to see. I just want to see what the chapter says at the end. It says here 2009. So there's a lot of changes since 2009 on things like gender identity disorder. For reference for people, was it Call Me Caitlin, the Bruce Jenner situation? That was during, I think, the early part of the Trump presidency, or it might have been in 2015 or something like that. So I'm going to look that up. I just want to, because this is relevant because, yes, social norms have changed in America. And that is actually influencing, they influence each other, the actual psychiatric and psychological communities on this stuff. Okay. So, the Call Me Caitlin, Bruce Jenner coming out as transgender situation was in July of 2015. So this book was written in 2009, my 5th edition that I'm reading from. Now, when was gender identity disorder removed from the DSM? So here, gender identity disorder was removed from the DSM in 2013 with the publication of the DSM-5. So that tells you a lot about how old this copy is. It's 5th edition, and it's working from a 2009. The DSM-5, which has been around for a while. I knew about the DSM-5 went back when I was in high school, right? This is from 2013, is when DSM-5 came out. The DSM-5 does not have gender identity disorder as a disorder. It was replaced with gender dysphoria, shifting the clinical focus from pathologizing that person's identity to diagnosing the distress caused by the mismatch between their gender identity and their assigned sex. And this was a similar process to what happened with homosexuality. I think in the DSM, was it 3 or was it which? I think no, DSM-1. I think DSM-1 had which DSM removed homosexuality. I think it was DSM-2. Yeah, DSM-2 removed homosexuality. Yeah, so even that, let's say for example, and I'll make this very clear to people. People viewing homosexuality as a mental illness, and then all of a sudden during the gay rights movement in the United States and other Western countries, they just magically discovered, oh, homosexuality isn't a mental illness. It's like, oh, what a coincidence, right? Kind of that kind of thing. What a coinkydink. How could you imagine they just figured out that it was no longer a mental illness the minute that there was a civil rights movement for it. That's weird, huh? Wow. I guess they just discovered some sort of crazy new study. It's like we can recognize and acknowledge the fact that the same way that we have activists that work in everything, in universities, who are focused in various industries, etc., and politics, obviously. There are also people who are activists or have a certain kind of political disposition who are influencing and pushing the envelope in a particular way in academia. And it's the reason that we see homosexuality as being, oh, this is not a mental disorder, and oh, now gender identity disorder, well, that's not really a mental disorder either. It is because of a change in the political landscape. Now, that doesn't mean in principle that these things are. I would contend the latter one is, I would say if you're a guy who thinks you're a woman, then yeah, I would say that's kind of some sort of disorder of the mind. In the case of homosexuality, I would just kind of view it as you being kind of a pervert, but paraphilia is considered a mental disorder, technically speaking. I mean, to me, it's more of a vice, depending on what you're talking about, I suppose. But it doesn't necessarily, in principle, mean that the current ruling is incorrect or a previous ruling was correct. It just reveals that the actual, quote-unquote, academic, totally empirical classification system that we're using is being influenced by cultural and political changes, which don't necessarily reflect real-world empirical studies. Now, of course, there was a study that was trying to dissociate homosexuality from a paraphilia, and I don't necessarily disagree with the point that there is a distinction between some male homosexuality and paraphilia. There definitely is. You can make the argument that there are some homosexual men who have a certain kind of androphilia, which might have a parallel to female androphilia. I wouldn't rule that out, but I also think there are probably homosexual men who have a androphilia that basically has little to do with anything that women do in terms of their androphilia, i.e. they have a certain kind of fascination with men that is very alien to female heterosexuality, and so can't necessarily be compared to it. Even the concept of a male homosexual or male homosexuality is probably a grab bag of several different underlying sexual or parasexual impulses that are reflected in a particular behavior, that is to say, men having sex with men. Right. I don't know if that sounds kind of outlandish to you, or that you don't know what I'm talking about, but when we're talking about psychiatry and psychology, what we're trying to do is look at this huge variation in human behavior, the moral and the immoral. Whatever kind of ethical system you would have to accept that some human behavior is probably not morally right. And that people do things that are kind of messed up sometimes. And vice versa. People do things that are good and so forth, or morally neutral. And then vice versa. And also there's behaviors that people do that are both normal and abnormal. Things that are both physiological and not necessarily problematic, and things that are maladaptive and pathological. And that we're trying to create a categorization scheme and then from there a treatment regimen based on of what we consider this, that, or the other. So it's, it's like everything else in the world. Humanity sees a great variation in how things are, and we create these sort of categories to help understand the world around us. And unfortunately, our categorization schemes are not necessarily perfect. And hopefully we have a system in place where we try to become more and more accurate about how we describe reality. But of course, like everything else, it's influenced by our own biases and cultural changes and etc. That kind of thing. Anyway, let's talk about paraphilias. Table 9.6 about paraphilias. We're talking about paraphilias before. I would say, some of these things seem a little bit more like a vice than necessarily a mental disorder. Seems like a strong word, but, let's talk about it. Exhibitionism. Sexual excitement is derived from exposing one's genitals to a stranger. Okay. Fetishism. Non-living objects are the focus of intense sexual arousal in fantasy or behavior. Okay. Frauderism. Okay, yeah. This is a little gross. Okay. Sexual excitement is derived from rubbing genitalia against or by sexually touching a non-consenting stranger. Pedophilia. Sexual excitement is derived from fantasy or behavior involving sex with a prepubescent child. Again, people use pedophilia, throw that around a lot. And it doesn't mean, for example, that if a guy, is in his 40s and he's doing uncouth things with somebody who's, let's say, 16 or something like that, it doesn't mean that's morally right. But that technically is not pedophilia. That is a distinct thing. That's more like an ephebophilia, I believe. Again, we're not making a moral case about whether or not people should be hitting on teenagers or something like that. But we have to acknowledge that when we talk about pedophilia as an actual psychiatric disorder, we're talking about the attraction to prepubescent, that is to say, people who've not gone through puberty yet, children, right? Anyway, sexual masochism. Sexual excitement, so that'd be like somebody below the age of like 14 or 12 or something like that. Somebody who's attracted to somebody who's like 8 years old, that's pedophilia. Sexual masochism. Sexual excitement is derived from fantasy or behavior involving being the recipient of humiliation, bondage, or pain. Sexual sadism. Sexual excitement is derived from fantasy or behavior involving inflicting suffering or humiliation on another. Transvestic fetishism. Sexual excitement in heterosexual men. Oh, in heterosexual men. Okay. No, is derived from fantasy or behavior involving wearing women's clothing. Okay, so if you're a gay guy and you like to do drag, oh, that's normal. If you're a straight guy who likes to do drag, oh, what is this pervert, weird freak? Psychiatric disorder clearly is shown. That's always a funny one. It's a fun. If you just talk about like male sexuality in the context of homosexuality, it's all sorts of weird stuff, right? But it's like these are things that you might see in a guy who's heterosexual too. But if you say you have a heterosexual guy, oh, he's into cross-dressing, oh, he's hypersexual, he wants to have sex with tons of women, oh, he's doing all sorts of weird stuff in the bedroom, and you say, oh, that guy's a weirdo, that guy's a freak, that guy's a pervert, And you talk about if you talk about a gay guy who does all the same stuff, you say, oh, okay, he's just gay. It's like, oh, wait a minute, what? Because all of a sudden now, well, he's just gay. What do you mean? So again, not an endorsement of this behavior. I think it should be kind of. I think people should have some reservation about what they do. However, there's a weird kind of carve out for gay men apparently. Voyeurism. Sexual excitement is derived from fantasy or behavior involving the observation of unsuspecting individuals undressing, naked, or having sex. Yeah. And I want to go into something a little bit about this as well. We were talking about before about paraphilias and stuff like that, or GID, some of these sexual disorders, and we're talking about, it has to show actual problems for that person's life. It has to be actually maladaptive. If you have some of these things going on, and it's not causing problems for you or for anybody else, it's not necessarily a disorder. So, for example, there are women, there's probably men too. There are men too, definitely. But there are women who are into some of these things, and there are men who are into some of these things. And if you're a person, for example, who's married and... Well, I guess they don't even have to necessarily be married, technically speaking. We're not talking about the morality of things. We're talking about the pathology of things. If you're a person in a relationship with somebody and you're doing some of these things, and there's no illegal behavior going on. Everybody involved is consenting. Nobody's being physically harmed in the process as a consequence of these things. People would typically say, oh, well, it's between two consenting adults in a bedroom. What do I have to do with that kind of thing? And likewise, psychiatrists who say, well, this person's engaging this mutually consensual behavior between them and their partner, and it's not harming anybody. They would say, okay, well, this thing which would otherwise be considered a paraphilia, let's say, for example, a person who likes, you know what, actually, I don't need to describe this for people. You get the idea. If it's causing problems for them in their life, they would consider, oh, that's paraphilia. If they're saying it's not causing issues for them, again, it's private, it's legal, it's consensual, etc., they would say, oh, that's not a pathology. So just bear that in mind as well. Again, this is not an endorsement of any kind of behavior in particular, but it's simply an acknowledgement of the fact that there's a distinction between what's considered psychiatrically or psychologically pathological and what's considered normal and what's considered moral. Those are three different things. There might be some overlap, right? You might say, oh, this guy has a completely normal sexual life with his wife, nothing crazy going on, and he's a pretty upstanding guy overall, pretty reasonable. And then there might be some, but it doesn't mean just because that's true, doesn't mean there might be cases where somebody's engaging in something that is immoral, but isn't necessarily a pathology, or maybe somebody's engaging in a pathology doesn't necessarily mean it's immoral, or, you could go down the list, right? Let's talk about sleep stages. Or let's go talk about this first, and then we can go back into the graph. Well, no, let's go do this first. Let's do this first. Let me just do this now. Another thing for reference, I'm going to go back into the thing I was talking about before. These are considered paraphilias. These are very common among people. Certainly among Zoomers, for better and for worse, probably for worse, I would say. Whether or not that's considered a pathology in them or not quite sure. And what happens if you have a situation where it's so normal and so acceptable that it's no longer considered culturally abnormal and therefore it's no longer technically a pathology? I don't know, right? It might still be problematic, right? It might still be an issue for people who do it, but if it becomes destigmatized, is that still a pathology? I mean, arguably, technically, no, from the perspective of the psychiatrist, but I don't know. Sleep stages. So we have non-REM, I think NREM, non-REM, 75% of total sleep time. So stage 0, awake. Stage 1, 5% of total sleep time. Very light sleep, transition from wakefulness to sleep, drowsy. Stage 2, 45% of total sleep time. Medium depth of sleep, occupies about half the night in adults. Serves as a transition stage between REM and delta sleep. EEG demonstrates sleep spindles and K complexes. Delta, slow wave sleep, comprises stages 3 and 4. Stage 3, 12% of total sleep time. Consists of moderate amount of delta wave activity, deeper sleep than stage 2. Stage 4, 13% of total sleep time. Increased delta wave activity over stage 3, very deep stage of sleep. What about REM, which is the 25%, which, by the way, REM means rapid eye movement, for reference. REM, 25% of total sleep time. Dream sleep, EEG is active, mimicking that of the waking stage. Depth of sleep is greater than the stage 2, but probably less than delta. There's a little thing here that says, for the little side note, or clarification note, I want to see what it's actually referencing in the first place from this. Okay, so for when it says here stage 1, it says here very light sleep. There's a little A, and then here it says here A. Depth of sleep, as used here for stage 1, is not a precise term, but generally refers to ease of arousability. That is to say, how hard would it be to awaken an individual from a particular stage? However, the ease of arousability is caused in part by this type of stimulus used, noise versus touch. EEG, electroencephalogram, non-REM, non-rapid eye movement, REM, rapid eye movement. Okay, those are just clarifications of what those mean. Okay. Sleep disorders. Sleep disorders are illnesses related to alterations in the sleep-wake cycle, Table 9.7, and often have effects on mood, cognitive, somatic, and general performance. Table 9.1 illustrates a normal sleep stage. Histogram and electroencephalogram characteristics of each stage. Table 9.8 outlines the DSM-4 classification of sleep disorders. Sleep disorders are categorized into primary and secondary sleep disorders. Primary sleep disorders are those disorders occurring as a direct result of disturbances in the sleep-wake cycle. They are divided into two categories, dysomnias and parasomnias, as dysomnia and parasomnias. Secondary sleep disorders are a consequence of other mental disorders, that is to say, depression, resulting from general medicine conditions, that is to say, somatic pain, or substance use, for example, caffeine. So we have a little chart right here showing midnight and the REM levels and the so 1 a.m., 2 a.m., 3 a.m., 4 a.m., 5 a.m., 6 a.m. And you can see the REM right there, and you can also see the stuff right here, which is showing the alpha rhythms, beta rhythms, theta rhythms, etc. I don't really glean all that much information from that. I can't make all that much of heads or tails from that, to be fair. A very limited comprehension of these graphs here. But if you do have a comprehension of it, go please pause the video and just absorb the information, or you can look it up online as well, which might be a little bit better. Figure 9.1. The stages of sleep through one night. A, this is the left graph here at A. Let me just do it like this, if I can do it like this. Here we go. A, this graph represents falling asleep at 11 p.m. and entering the non-rapid eye movement REM sleep stage 1. The night's sleep progresses with the deeper stages of non-REM sleep, slow wave sleep or delta sleep comprising stage 3 and 4 of non-REM sleep, occurring more intensely in the early portion of the night. REM sleep increases in duration, and slow wave sleep declines as the night progresses. The cycle is repeated several times, with REM sleep occurring at approximately 90-minute intervals in healthy adults. Now what about the second diagram, B? Electroencephalographic rhythms during the stages of sleep. So again, this is what it looks like here. Anywho, dysomnias are 5 primary sleep disorders consisting of disturbances in initiating and maintaining sleep, feeling rested or refreshed after sleep, or sleeping excessively. Table 9.9 defines the DSM-4 determined key characteristic of each disorder. Chronic insomnia. Of the sleep disorders, none is more prevalent in psychiatry than insomnia, either of primary origin or associated with other conditions such as anxiety, depression, or psychoactive substance use. Chronic insomnia is not an official DSM-4 category, but is a clinical subcategory arising from both primary and secondary insomnia and mixtures of the two. Insomnia can generally be considered chronic if it is greater than 6 months duration. An estimated 15% of people have chronic insomnia. Factors increase the risk for chronic insomnia include advancing age, psychiatric illness, medical illness, and social stress, work, relationships, etc., and female gender. The treatment of chronic insomnia remains a major challenge. Cognitive behavioral therapy, CBT, and relaxation therapy may be helpful. Modest effects have been noted for sleeping agents of various classes. Antidepressants may also have some effect, but may also cause insomnia. There is a risk of benzodiazepine dependence from chronic use of benzodiazepines. Improved sleep hygiene in the form of regular sleep-wake cycles, avoidance of caffeine, and regular exercise may also prove to be beneficial. And also, there's alternatives to benzodiazepines. If you want to use I don't know if they go into it or not, but if you don't want to use a benzodiazepine because you don't want to be dependent on it, there are alternatives like zolpidem. Let me say this. What are these? Like zolpidem, ezoplaclone, and zaloplan. So these things, zolpidem, ezoplaclone, and zaloplan, they basically act at the same site as where a benzo would act on, but they do not have the same dependency issues necessarily. They are non-benzodiazepine prescription medications used to treat insomnia. These are the Z drugs. It's very easy to remember because, when you're using them, you're getting the Z's. You know what I'm saying, dog? Okay? So anyway, there's also things called Ramelteon, which is like a melatonin like a melatonin receptor agonist. I think it works on one of the melatonin receptors. It's basically it basically acts the same way that melatonin would typically act. And again, those are going to be, for melatonin, it's another way for you to have sleep that's not necessarily going to be inhibiting or impacting, or would not be a problem with dependence, like the way benzos might have a dependence problem with it. So bear that in mind. They are alternative medications to benzos for sleep. Let's talk about sleep disorders. Primary sleep disorders, secondary sleep disorders. So let's talk about primary. We have dysomnias, we have primary insomnia, primary hypersomnia, narcolepsy, breathing-related sleep disorder, and circadian rhythm disorder. Those are all primary sleeping disorders that are dysomnias. What about secondary sleep disorders, dysomnias? We have sleep disorder related to another mental disorder, sleep disorder caused by a general medical condition, and then also substance-induced sleep disorder. Okay, so those are dysomnias. What about parasomnias? Okay, you can have both, I guess. We have for primary parasomnias, we have nightmare disorder. That doesn't sound fun. You get diagnosed, what do you have? Nightmare disorder, okay. Sleep terror disorder, that does not sound fun either. And sleepwalking disorder, that's also probably not great. What about table 9.9? So now we're on table 9.9 for primary sleep disorders. We have dysomnia, so you were talking about before, primary insomnia, difficulty falling asleep or staying asleep, or sleeping but feeling as if one has not rested during sleep. What about primary hypersomnia? Excessive sleepiness, either sleeping too long at one setting or persistent daytime sleepiness not relieved by napping. What about narcolepsy? Sleep attacks during the daytime coupled with rapid eye movement, sleep intrusions, or cataplexy, sudden reversible bilateral loss of skeletal muscle tone. Daytime naps relieve sleepiness. Okay. Breathing-related sleep disorder. Abnormal breathing during sleep leads to sleep disruption and daytime sleepiness. Circadian rhythm sleep disorder. The sleep disturbance caused by a mismatch between a person's intrinsic circadian rhythm and the external sleep-wake demands. We have parasomnias. Parasomnias, we have nightmare disorder. Repeated episodes of scary dreams that wake a person from sleep usually occur during rapid eye movement sleep. What about sleep terror disorder? Repeated episodes of apparent terror during sleep. Individuals may sit up, scream, or cry out and appear extremely frightened. They do not usually awaken during the attack. Occur during delta sleep. And what about sleepwalking disorders? Recurrent sleepwalking, often coupled with other complex motor activity. Okay, so that concludes the main corpus of our chapter. We're going to have some key points for summary. Somatization disorder is a type of somatoform disorder. The symptoms of somatization disorders are subconscious in origin. Treatment of somatization disorder includes cognitive behavioral therapy, antidepressants, and single physician structured treatment. Paraphilias are sexual behaviors or interests that are considered culturally unusual. The primary sleep disorders include the dysomnias and the parasomnias. Sexual dysfunctions are categorized according to the phase of the sexual response cycle during which they occur, or to the presence of pain. Factitious disorder is characterized by the willful production of symptoms of illness in order to assume the sick role. Oh, weird. We actually have more content. Okay. For some reason, okay. For some reason, they ordered it like that. Okay. Sure. Whatever. Parasomnias. Going back into this. Parasomnias are a triad of sleep disorders associated with complex behavioral events that occur during sleep or that arouse a person from sleep. The disorders are defined in Table 9.9. Factitious disorders. A factitious disorder is one in which an individual willfully produces signs or symptoms of a medical or psychiatric illness to assume the sick role and its associated gratifications. This should be differentiated from somatoform disorders, which are not willful, and malingering, which is simply lying about symptoms or signs to obtain gains or different from those obtained by assuming the sick role. That is to say, to avoid the military or for monetary gain. So again, for a distinction here, if a person reports symptoms and they're not lying to you, but it's fundamentally not an issue of their body. Their body's totally okay. But they say they have symptoms and they believe they have symptoms. They feel pain or something like that or disturbances. That is called somatoform disorder. That is that kind of condition. If a person does have symptoms, but they're causing the symptoms to happen in the first place because they want to take on this sort of sick role, that's called a factitious disorder. They're inducing symptoms in order to get treated for symptoms. That's factitious disorder. And I think there might be a new name for that as well. I'm not quite sure. It's also called, no, it's still called factitious disorder. Okay. Then the third thing is called malingering. The person says they have symptoms. They're just lying to you. They're just lying to you because they want to get something from you. They want to get drugs from you. They want to get some sort of monetary compensation. They're going to go to court for some reason. They want to get out of the military for some. That's called malingering. When they're just straight up lying to you, they have no symptoms. They're just being dishonest with you. That's called malingering. A little bit of a different situation. Anyway, that concludes Chapter 9. Yes, Chapter 9. If you enjoyed this reading, smash that like button. This was just under an hour. This is 56 minutes, 12 seconds of counting and so forth. So, if you enjoyed that chapter, hopefully it was of good use to you, good utility to you. Hopefully the ranting and raving that I had was not too problematic for you. It was not too distracting for you. But hopefully it was useful to you. I don't know, right? Hopefully it made you think a little bit about our current understanding of the variation in human psychology. I don't know. And for that matter, the development of academia in Western countries, for that matter. Anywho, hopefully this was of good use to you, and hope you have a great rest of your day. Thank you, and